Hi, welcome to today's episode of OBGYNugget with Dr. Aditya. The topic for today is a dilemma that a lot of people face, but we often tend to overlook. In fact, even I did it during my residency, but it's a very interesting debate and something that I would love if you all know on which would be a better choice to make in the benefit of your patient. So the topic for today is going to be dexamethasone versus betamethasone and which is a better pick as an antenatal corticosteroid cover for that mother and for the baby. So first of all, let us discuss as to why are we giving any corticosteroid in a female. So these antenatal corticosteroids, I'll call this ACS, are given in especially in preterm patients and babies who might be delivered preterm because the rate of it increases the rate of pulmonary maturation. So the baby's lungs are going to be developed much faster and better when you're giving this. So how does this happen? The mechanism of action, well, the evidence is not great, but whatever the evidence says, it says that this increased rate is because of two main reasons. The first one is that the steroid that you're giving, first of all, forms a substrate. When I say a substrate, it means that substrate is basically a raw material. It forms a substrate for the formation of surfactant. Now, surfactant, what is a surfactant? Surfactant is a fluid that is present in your lungs which reduces the surface tension. That surface tension requirement is, the surface tension has to be reduced. The requirement has to be low for the surface tension because whenever that baby takes the first breath, all those alveoli have to open up at delivery. So when the surface tension is going to be low, the risk of respiratory distress, the amount of effort that the baby will have to put in, will be much lower if the surfactant is adequate. Now, this surfactant is formed around 35 or 36 weeks of gestation, but definitely after 34 weeks of gestation. Now, because this is the case, babies who are going to be delivered before this period, they will lack the surfactant and they will have something called as respiratory distress syndrome because they'll find it a lot more difficult to breathe with lesser amount of surfactant. Now, this corticosteroid is going to form one of the substrates, one of the raw materials for the production of surfactant. And the second and the most important one is that it increases the action and formation of type 2 pneumocytes. Now, there are two types of pneumocytes, of which the type 2 pneumocytes are the one which increase the production or which produce surfactant. So it is going to increase the activity of these type 2 pneumocytes. So basically the overall action is to increase the surfactants. There is also one more action that is being suggested, and in that they say that all your alveoli which are formed, it increases the rate of formation of alveoli, something that we also call as alveolization. And in alveolization, it increases the formation of alveoli. Now, alveoli are the places where the gaseous exchange takes place between the capillaries, the pulmonary capillaries, and the alveoli. So, when these alveoli are formed, the distance between those capillaries and the alveoli decreases, which helps in gaseous exchange and again reduces the chances of respiratory distress syndrome. So, both these things combine to reduce the risk of respiratory distress syndrome in the baby. Now, when I will talking of this, the next question that should arise is that what are the drugs that are available with me? So I have betamethasone, which I give very often, and then I also have dexamethasone, which also a lot of hospitals prefer to give. Now, before I go ahead with the question on which is a better drug, I'll just give you a tricky question over here. The question is, imagine your female has some autoimmune disorder for which the patient is already consuming prednisolone. And the disease might be something like SLE, systemic lupus erythematosus, or she might have ITP, immune thrombocytopenic purpura, and she's consuming prednisolone since a long time. Now, would you give a corticosteroid cover for antenatal corticosteroid cover for the baby's benefit in these patients? The answer is an emphatic yes. The reason being, these two drugs, betamethasone and dexamethasone, are chosen because they cross the placenta in quantities that are adequate for the baby's pulmonary maturation to happen. Whereas drugs like prednisolone do cross, but a lot of them are metabolized in the placenta itself, and hence they do not reach the baby in concentrations that will be required for pulmonary maturation. And hence, betamethasone and dexamethasone are those two drugs which cross your placenta. So then coming back to the question of beta versus dexa, which one is a better one? The first basic that we should know is which is the compound of beta and dexa that we use. So betamethasone has two major compounds. One is phosphate which is actually the one that we often get readily in our markets in India. And the better one is acetate and phosphate, basically a combination of these two salts. So this is said to be the better one, but unfortunately we do not have an abundant availability of this salt in India. In fact, I have myself not seen it. The one that I get easily in my hospital, and since I'm getting it since the last few years, is phosphate, and hence we tend to use phosphate. But the downside of this is that this increases the risk of getting cerebral palsy. Now, what is the clinical significance of this part? We are often told by our seniors not to give multiple doses of corticosteroids. So what does this mean? Now, whenever you're giving any corticosteroid for fetal maturation, it takes a bare minimum of evidence has shown it takes a bare minimum of 18 hours for the lungs to develop. So when it takes 18 hours for the lungs to develop, this action can go on until 7 days. So a lot of people, if 7 or more days have elapsed since the last dose and the baby has not yet delivered, they tend to give a rescue dose. Now, the evidence regarding rescue dose is not too good or too much, but we still prefer to give it. A rescue dose is basically repeating the same dose after 7 days. But mind you that that rescue dose should be given just once. If you are giving it multiple times, it is going to increase the risk of the baby getting cerebral palsy, and hence, at most, you give one rescue dose or not even that. The second point is, what about Dexa? In Dexa, the drug or the salt that is available is again phosphate. We do not get any other salts. Now, what is the dose? Betamethasone is given in the dose of 12 mg. It is given in the dose of 12 mg that we give 24 apart, two doses. So 12 mg into two doses, 24 hours apart. Whereas this is given in the dose of 6 milligram into four doses into 12 hours apart. So if you calculate at the end of the day, 12 into 2, you're giving 24 mg of betamethasone, and again 6 into 4, 24 mg. Just that the frequency matters. The frequency is more, or the duration, or I just say frequency of giving the dosage is more in dexamethasone, and that is the reason why it is a preferred drug. Why? This has to be given more number of times because it has a shorter half-life. But a shorter half-life also means a faster onset of action. And this faster onset of action is what makes it a very good drug, and it is as fast as 4 to 6 hours. Now, what and how does it make better than betamethasone? So, if I'm going to be making a chart again for beta versus Dexa, because dexamethasone has a lesser half-life, half-life, and it has a faster onset of action. If I'm going to be talking about the mother and the fetus over here, so if the mother is at a very high risk of delivering within the next 12 to 18 hours, I would need a drug that is acting very quickly on the baby. So in that terms, it is a very good drug to be given. Dexamethasone works very well more than betamethasone in terms of onset of action. Secondly, in females who are having PPROM, that is preterm premature rupture of membranes, they are at a very high risk of developing chorioamnionitis. Now, whenever you are giving these steroids, if you are going to check the mother's sugars, they'll be increased by almost 100 to 150 or even 200. If you're going to be just checking them, they'll be increased. Now, high sugars form the substrate for microorganisms to grow and cause sepsis. And they can grow in that amnion or chorion fluid, the amniotic fluid that is coming out, and they can lead to chorioamnionitis. So now you need a drug that will also help in pulmonary maturation, but also won't stay in the mother for too long to give an increased risk of chorioamnionitis. So in that case, dexamethasone, given that it has a shorter action and a faster onset of time, it is better than betamethasone. Also, in patients who are diabetics, in mothers who are diabetes, known case of diabetes mellitus, if you are giving these steroids, they have a risk of going into diabetic ketoacidosis, DKA, and hence we often give in these patients corticosteroids with covering of insulin. Now, you in this case need a drug which will act fast and will also be removed from the system quickly. And again, in this case, dexamethasone is a better drug than betamethasone. So these are the three maternal reasons why dexamethasone is a far superior drug than betamethasone, whereas in fetal reason it has shown that it reduces the chances of intraventricular hemorrhage and cerebral palsy, and also improves neurodevelopmental outcomes, NDO. Both of these are seen better with dexamethasone. And hence, if I'm finally going to be talking on which is a better drug for all these maternal and fetal indications, I would say that dexamethasone by a large margin beats betamethasone. There is also a trial if you wish to read about it. The trial's name is Beta Code trial. If you read about it, you would know why has dexamethasone been preferred, and hence if you're asked about this in your exam on which is a better drug and which drug would you prefer, the answer is going to be dexamethasone over betamethasone. Though 19-20 का ही फर्क है, I would say ज्यादा तो फर्क है नहीं, but even these minor differences can make a big difference to the outcome of the baby and also to the medical comorbidities of the mother. And hence, dexamethasone, if you have the availability of it, prefer it over betamethasone. That's it for today's OBGY Nuggets. Hope you had a great learning session with us. Thank you.